Oh, my mic was, yeah, we are going live.
Yeah, ma'am.
Yeah, we are live now.
Good evening, all. Today's second topic is presented by Ms. Dipal Patel from Sardar Patel University from the Occupational Therapy Department on the topic spinal cord injury. So, proudly thanking Dr. Chandramohan, ExRxIndia's founder, Mr. Sampath Kumar, CEO of Sri Samraj Health Service Private Limited, Professor Dusat Creations creator, and finally, I thank all the students, those who are presenting and attending this webinar series. So we can proceed, Deepal.
Greetings of the day, everyone. Myself, Dipal Patel, a final year occupational therapy student from Sardar Patel University, Gujarat. Today, I am going to present a topic on spinal cord injury. First, I will start with the anatomy of spinal cord. As all of you know, spinal cord is a long, thin, tubular structure made up of nervous tissue extending from medulla oblongata, going through the foramen magnum to lumbar region of vertebral column. It is a part of central nervous system that conveys information between brain and body. There are 31 pairs of spinal nerves, out of which 8 are cervical, 12 are thoracic, 5 lumbar, 5 sacral, 1 coccygeal pair of spinal nerves. The outer layer of spinal cord is made up of white matter and the inner or central layer is made up of gray matter, which is H-shaped. The physiology of spinal cord. The purpose of spinal cord is to send motor commands from the brain to body and the sensory information from body to brain, as well as to coordinate reflexes. Now, as you can see in this diagram, the cervical spinal nerves supply the breathing, head and neck movements. They are responsible for heart rate and shoulder movements, wrist and elbow movement, hand and finger movement. Thoracic T1 to T12 are responsible for the sympathetic tone, temperature regulation, and trunk stability. And the sacral segments are responsible for sexual function. Lumbar segments are responsible for knee extension, ejaculation, and hip motion. And the S1, L5 S1 is responsible for foot motion and knee flexion. What is spinal cord injury? So, whenever any damage occurs to any part of spinal cord or spinal nerves causing temporary or permanent changes in function, strength, or sensations below the site of injury is called a spinal cord injury. Every year around the world, about 2.5 lakh to 5 lakh spinal cord cases occur, out of which most of the cases are preventable. There are two main causes of spinal cord injury: traumatic and non-traumatic. The traumatic causes are contribute to higher percentage of spinal cord injury cases. The traumatic causes include falls, sports injuries, motor vehicle accidents, industrial accidents, diving accidents, violence, gunshot or scab wound, and assault. The non-traumatic conditions include tumors, cancer, amyotrophic lateral sclerosis, meningomyelocele, syringomyelia, multiple sclerosis, and loss of blood supply. Now, what are the outcomes or results of spinal cord injury? A spinal cord injury can result in quadriplegia or paraplegia. It cannot result in hemiplegia. A spinal cord injury may result in quadriplegia, which means whenever there is any degree of paralysis in all four limbs and the trunk musculature. And paraplegia is paralysis of lower extremities. Whenever there is cervical lesion, there is more chances of quadriplegia, and whenever there is thoracic or lumbar lesion, there are more chances of paraplegia. And cervical, whenever any cervical lesion occurs, there are chances of higher cervical lesion and lower cervical lesion. Higher cervical lesion causes more disability than lower cervical lesion. Types of spinal cord injury. There are two types of spinal cord injury, a complete spinal cord injury and incomplete spinal cord injury. Complete spinal cord injury results when there is complete loss of motor and sensory function of spinal cord below the level of injury. When there are no sensations or no motor function below the level of lesion, a complete spinal cord injury may occur. An incomplete spinal cord injury. In incomplete spinal cord injury, there is some degree of motor and sensory function below the level of injury. That means complete spinal cord injury is there is complete intersection or transection of the spinal cord resulting in no motor or sensory function, and in incomplete spinal cord injury there may be some function present. And so the incomplete spinal cord injury is of many types while complete spinal cord injury is only one. Now, the types of incomplete spinal cord injury. They are categorized according to the area of damage. There is central cord syndrome, Brown-Sequard syndrome, anterior spinal cord syndrome, cauda equina syndrome, conus medullaris syndrome. Now, I will explain each of them in detail. Central cord syndrome. Whenever there is more central damage to the spinal cord, then it results in central cord syndrome. There is paralysis and sensory loss more in the upper extremities than in the lower extremities. Brown-Sequard syndrome. It occurs when only one side, only of full spinal cord, only one side of the spinal cord is injured, then it results in Brown-Sequard syndrome. It is also known as lateral cord syndrome. Whenever it occurs in gunshot or stab wound, there is a motor paralysis and sensory loss on the ipsilateral side and loss of pain, temperature, and contralateral sensation on the contralateral side. Ipsilateral side is the same side and contralateral is opposite side. Anterior spinal cord syndrome. Whenever any injury occurs to the anterior spinal artery or the anterior aspect of spinal cord, it results in anterior spinal cord syndrome. It involves paralysis and loss of pain, temperature, and touch sensation, but the proprioception is preserved. Cauda equina syndrome. Cauda equina syndrome does not directly involve the spinal cord, but it involves the peripheral nerves, and it results in flaccid paralysis. Conus medullaris syndrome. Conus medullaris syndrome involves injury of sacral and lumbar nerve roots, causing areflexic bladder, bowel, and lower limbs. Now, what happens after a spinal cord injury? Whenever a spinal cord injury occurs, the individual enters a stage of spinal shock lasting for 24 hours to 6 weeks. As all of you know, whenever spinal cord injury occurs, the patient goes into stage of flaccidity and then develops spasticity. It occurs due to stage of spinal shock. It is a period of areflexia. Reflex activity ceases below the level of injury. The bowel and bladder become atonic or flaccid. The deep tendon reflexes are decreased. Sympathetic functions are disturbed. After that, the spinal cord is not damaged below the level of lesion. For example, if there is a T1 injury, then the spinal cord below that is completely intact. So the muscles that are innervated by T2, T3, and all will remain, will develop spasticity. The deep tendon reflexes become hyperactive. The bowel and bladder become spastic, and the sympathetic activity is increased. The clinical features of spinal cord injury depends on the level of injury. There may be breathing difficulties, sensory changes, pain, weakness, loss of normal bowel and bladder function, and paralysis. The diagnosis. Radiological diagnosis usually includes, and it is more helpful when we are suspecting a non-traumatic spinal cord injury. X-ray, CT scan, MRI, functional MRI, and ultrasonography. Now, for clinical diagnosis, there is a scale called Asia Impairment Scale, that is American Spinal Injury Association Scale. It has different levels, Asia A, B, C, D, and E. In Asia A, there is complete lesion. That means there is no motor or sensory function. In Asia level B, there is an incomplete lesion. That means there is some amount of sensory function, but no amount of motor function present. In Asia level C, it is an incomplete lesion. That means some amount of sensory function and less than 50% of motor function is present. In Asia level D, sensory function is present and the motor function is present more than 50% in the key muscle groups. And Asia level C, E, it is normal. All the motor and sensory functions are proper. This is the Asia impairment scale. It has to be taken in this much detail as you can see in the picture. Complications. Now, whenever spinal cord injury occurs, due to the long time that it requires in rehabilitation, the following complications can occur. Bed sore or decubitus ulcer. It can occur due to staying in long time in bed. Orthostatic hypotension, heterotropic ossification, spasticity or contractures, bowel and bladder dysfunction, edema, deep vein thrombosis, osteoporosis, sexual dysfunction, pain, autonomic dysreflexia. Medical management. So, as a professional, we should also know the emergency management of a spinal cord injury. Whenever a spinal cord injury occurs, the management of spinal cord injury begins at the location of accident. The techniques that are used in stabilizing, moving, or managing the patient immediately following trauma can influence the prognosis highly. Whenever a spinal cord injury is suspected, efforts should be made to avoid both active and passive movements of spine. Sometimes what happens, the spinal cord injury is not that much deep, but whenever people try to move the patient, it becomes more critical case. So we should not try to move the patient if we suspect a spinal cord injury. Instead, we should wait for an ambulance or some person that are trained in it. The movement of spine is reduced by stepping the patient to a spinal backboard or a full body adjustable backboard that is primarily stabilizing the spine. Using support cervical collar, we also have to stabilize the head like this. As you can see in the picture, the spine of the patient is properly stabilized on a spinal backboard and the head is also supported on a cervical collar. Medical management. On arrival at the emergency department, initial attention is focused on stabilizing the patient medically with a primary emphasis on ventilation and circulation. Cardiac, hemodynamic, and respiratory status are closely monitored. High doses of methylprednisolone may be given early after the injury within 3 to 8 hours of injury for 12 to 24 hours, and it has proven to be very much effective if given within 12 to 24 hours. Now, the surgical management of spinal cord injury. There are only two options, spinal decompression surgery and spinal stabilization surgery. Prognosis. The prognosis depends on the level of lesion. An incomplete lesion, Asia B, C, and D, has a good prognostic indicator, and there are more chances of recovery. Whereas incomplete lesion with cervical injuries, there are less likely to experience proper recovery, but recovery may occur in 70% of cases. Thank you.
Yes, Dipal. It was wonderful session and had an informative session for the last 20 minutes or so. So
Thank
I
you,
take
sir.
this opportunity to thank your HOD from Sardar Patel College. And we'll sign off for today's student session and we'll meet in our premier session at 7 p.m. Bye bye.
Thank you, sir.
Welcome.